Hi guys, this is Professor Elliott. Let's talk about chapter 32, diabetes drugs. All right, this is a really big conceptual guide about diabetes. Diabetes is probably the most important endocrine disorder and the most common. So this conceptual guide kind of tells you overall about what we're talking about. You'll learn about this disease a lot more when you're in med-surg, but I think it's important to lay the foundation here. So what is diabetes? I think that's the most important thing to talk about first. So diabetes and insulin go hand in hand. We need to know what insulin is and what it does in order to understand diabetes. So insulin's whole purpose is to increase glucose transport into the cell. So right here, these little yellow guys are glucose. When we have insulin, it can open up the channels to allow the glucose to go into the cell. The cells need glucose, and the cells also process the glucose to allow your body to decrease your blood sugar level. So diabetes in general, we see an elevated blood glucose level. Type 1 diabetes has no insulin, and type 2 diabetes has a reduced insulin. So with type 1, you can see this picture over here. This is an example. The blood glucose is attempting to enter the cell, but since it has no receptors for insulin, the insulin cannot work to open up the channels to allow the glucose to enter the cell. So this is basically a really fancy way of saying with diabetes, our insulin, we don't have it or it doesn't work, and the glucose just builds up within the bloodstream, and that's why we have high blood sugar levels. Now the pancreas is really important because it's basically where the insulin is made. Here is an example. I like this example because it involves a donut. So this person eats a donut. Their body breaks down the donut into components that can be absorbed into the bloodstream. Now the glucose travels, the blood sugar travels along the bloodstream, and it goes into the pancreas. And the pancreas says, oh, hey, this blood sugar level is pretty high. Let me produce some insulin. And that happens at the beta cells within the pancreas. So the blood sugar is high, it's going through, the beta cells in the pancreas say, here's some insulin, let's fix this situation. And then the insulin goes, and it activates the insulin receptors, which allow the blood sugar to get into the cell. Glucose is really important because it feeds our cells. The excess glucose we have is stored in the liver as glycogen. So we just store that extra sugar as glycogen in the liver. And this is an important thing to know because as we talk about how these drugs work, some of them work by preventing glycogen from turning back into glucose. So glycogenolysis is a process where glycogen is converted back into glucose. So some of the drugs will stop this process, which allows us to continue to keep the glucose levels low. Now, glucagon is something we talk about, and it's the hormone that initiates the glycogenolysis. So it's the hormone that transports glycogen back into glucose. And I know there are a ton of G words, but glycogen is in the liver, and glucagon takes the glycogen and turns it into glucose. So diabetes, we either have no insulin or we have not enough insulin. Now you remember that we had those receptors, right? Those insulin receptors. Now sometimes the insulin receptor just isn't very good. So we have like this insulin resistance where we still have the insulin, but the receptor just isn't very good, so it doesn't work very well. Okay, 2 ways that we treat diabetes. We have insulins and oral antidiabetics. So we talked about how your beta cells make insulin, which goes throughout your body and opens up those channels, which allows the glucose to get into the cells. So we're basically just giving insulin to patients. Our biggest concern with insulin is that it's going to decrease the blood sugar. I'm going to abbreviate that BS for the remainder of the lecture, blood sugar. So our biggest concern is hypoglycemia. Hypoglycemia is low blood sugar. So you should always check the blood glucose prior to administering. We do have some interactions. Drugs like corticosteroids can increase the blood sugar level, and that's something you want to be aware of. Insulins are given in units. So you would give like 10 units of insulin. You would never give a milliliter of insulin. You would give like 10 units of insulin. The normal concentration we see is going to be 100 units per ml. We do have some formulas that are stronger, like 500 units per ml. Your big concern is so 1 ml is tiny, it's like teeny tiny. So you have 100 units in 1 ml. That means if you gave the person 1 ml, they would have 100 units, which is a crazy amount of insulin. That's just like too much insulin for a lot of people. So that's really dangerous. So I need you to know that you're going to use an insulin syringe. That's important to know. So just think this is an incredibly high risk drug. So you're going to think danger, caution, danger, caution. The insulin is given subcutaneously. So most of the time we're going to use a 27 to 29 gauge needle, a really little needle that's 1/2 inch long. Some patients have insulin pumps and it's just basically like a machine that gives them insulin. The only insulin we can give IV is something called regular insulin. So I'm going to take you through, we have rapid acting insulin, short acting insulin, intermediate, and long acting insulin. So 4 different types, and it's all based on how quickly they work if you didn't gather that by their names. Rapid acting insulin, we have these 3 here. So Lispro, Aspart, and Gluceline. Their onset of action is typically less than 15 minutes, sometimes 10 minutes, so that's pretty quick. If you're going to give a patient that works, or if you're going to give a patient an insulin that works that quickly, you need to know what their blood sugar is, and you need to have food available for them. These medications typically don't last very long, like 3 to 5 hours, 3 to 6 hours. Our short-acting insulin is called regular insulin, which is such a funny name. It's literally just like regular insulin. So this acts 30 to 60 minutes. It's short, so it's longer than rapid, but it's shorter than intermediate. Get where I'm going with that? So it's short-acting insulin. Our duration of action is 6 to 10 hours, and it's going to be the only one you can give IV. And then intermediate acting is this crazy name, insulin isophane suspension, but we call him NPH, like Neil Patrick Harris. We call him NPH. So it is cloudy or opaque. It's the only one that's going to be cloudy or opaque. And that's just important to know. The rest of them are clear. This is cloudy or opaque. So he's just kind of an independent guy. Onset of action is typically 1 to 2 hours, and it lasts a lot longer intermediate acting. It lasts a lot longer than the other ones. So it would be 18 to 24 hours. And now we have our long acting, insulin glargine and insulin detamere. So they're long acting. They're going to last from anywhere from 10 to 24 hours. This may be something that you can give once a day. So here's a chart. Rapid, you typically give with meals. Intermediate, you typically give twice a day. So high-risk medication for all. I like to learn these by the generic